Anthony, when do you think we should be measuring MRD?
So I think it also depends which regimen you're using. So I know if you use the Alliance AYA regimen, then they do it, I think where it was most significant was after the induction therapy, which showed the greatest risk of predicting for outcome. If you're using a German ALL protocol, they do it at week 16, which would be after the consolidation treatment, and that's where all their data has been generated. If you use hyper-CVAD, I think it's after part B, after cycle 1. I'm not sure if it's...
They have 2 time points for assessment. They say basically once hematologic recovery occurs, so within about 30 days or so of cycle 1A, usually before cycle 1B, and then they do another assessment at month 3 on average. How that addresses the number of cycles, for patients is not something, but I suspect it's going to be after 3B or so for most patients.
So I think basically you have to learn what regimen you're using, and then at what time point your MRD is significant enough to make a change in treatment.
I think the important also point is that just making sure that not to consider regular flow. I think we all talk about MRD, and there has to be a certain sensitivity for the MRD, the definition to be met in 10 to the minus 4. So I think the one thing that could potentially happen is that when you get a regular flow, which is not to the level of sensitivity, and that you assume the flow is negative, and then you assume that it's MRD negative, when in fact it's really not, because you're not achieving that level of sensitivity. So I think the one thing is that we should be aware that is it true MRD that all the publications are talking about, or this conventional flow and then with the less sensitivity that you're just assessing. So I think that's making sure that everybody's talking about the same definition, at least the same definition. Of course, you can go deeper with an NGS and then the prognostic implication of that. And the NGS, I think another factor to remember that you do need a diagnostic material in order to follow the clone.
Correct.
So if you don't send it at the time of diagnosis, unless you can retrieve it, which is possible, and you can definitely do. But I think these are factors to consider when you see newly diagnosed patients, that these are a critical component to look for this kind of the original clone so that you can follow these patients. For flow, you don't need them, but I think these are kind of the benefits of both. But I just strongly believe they should be tested, because we all do. But these are the factors to consider, I think, kind of when you see new patients. And I think especially when there's an MRD-directed therapy available and then there's prognostic significance at the end of consolidation, for sure, is a very important point. Induction, I think at that point, I think is more data depending on the regimen. But
I agree, it needs to be sent to, if you're looking for MRD, it needs to be sent to a reputable flow lab that deals with looking at MRD analyses and is experienced. I wouldn't just send it to any new lab that's just popped up.
The flow is so complicated, and even that to be certified, and it took many months, years for in our centers to establish that. So I think I just didn't want, there's no false assurance, and then they also depending on when you send the flow from what aspirate, it has to be kind of the first pull to get the best result.
That's the most important factor to get a reliable flow.
And if you send it at the fourth pool, then
it's meaningless.
It's meaningless, exactly. So I think these are kind of the details need to be discussed.
Yep, and also it's not just the number of colors. It's also the number of events. And that means you have to be very, very careful about asking MRD questions on very hypocellular marrows. And I think that's something else that often gets lost in the shuffle.
I think we're talking about standardization of the assay, and our pediatric colleagues have the advantage of using 2 flow labs in the United States, so that have cross-referenced each other, so they have standardization, where that's a challenge in our adult world.
But I think in the future, NGS is going to probably take over, and because one, you probably can send the test from the peripheral. You won't have to repeat bone marrows. You can send it from the peripheral blood. I mean, the sensitivity may be 1 log lower than what you would get off the bone marrow. It's easier to send from the blood, and you can send it at the different time I mean, I'm not sure what the cost differential would be.
And that's the bigger
Yeah,
issue,
correct.
is how, and that's why I brought up the difficulty with having to order it before you know what the marrow shows, and what does it mean if you're ordering this NGS MRD assay and then your pathologist says there's 20% blast. Okay, I just wasted a lot of money here.
Well, you can, I think you're able to cancel it if you, yeah, hopefully the pathologist can look at the morphology the same day. The other one you have to ship out, so
the
you may
DNA,
be
yeah.
able to cancel, yeah, yeah.
I think the turnaround time is important because I think when you need to make a real-time decision very
Yeah,
soon, the flow is very useful to do that. Sensitivity is very useful during maintenance or consolidation when you're monitoring them. So there may need to be a different value. The one assays may serve the better purpose during the kind of the later part of the day when you can actually tolerate 7-day or even longer turnaround time. That's typical when you need to make it. The flow has an advantage, and because of the expression of 19 and 22, at least for the B, ALL, and I think it's an important factor. So we're still doing both at the same time, but eventually, as we get more data, perhaps during one point of the time, the one test may be better, and then the other time, the NGS may take over. Especially in the peripheral blood monitoring, the later time point is very attractive and useful with a good sensitivity during the consolidation and the maintenance portion that you're just simply trying to monitor the patient's progress there.